Hello to all of our quality-minded listeners, and a special shout out to our Mayo Clinic Care Network members. Welcome to Key into Quality, a Mayo Clinic podcast focusing on healthcare quality. Thanks for joining us. I'm Dr. Tim Morgenthaler, a professor of medicine here at Mayo Clinic and a vice chair of Mayo Clinic Quality. I'm your host, and today we're tackling a topic that's both timely and crucial, dealing with the rise of rude and violent behavior in hospitals and its far-reaching consequences. Co-hosting with me today is Sherry Nemec. Sherry?
Welcome, everyone, for joining us. I'm Sherry Nemec, Consultation and Relationship Manager for Quality at Mayo Clinic. And you know what? You're right. I'll use the word miffed with just I think, behavioral changes that we're seeing with visitors and patients within the healthcare setting.
Yeah, Sherry, I think we've had some prior podcasts talking about physical violence, and
Yes.
that's certainly despicable and everybody can see it. But today we're going to be maybe touching on some little bit more subtle things, and I think it might be fun to do things a little differently. I have a little script that I want us to pretend that we're real life, just to demonstrate to our listeners the kind of things that might happen. Is that okay? Are you willing
All
to play
right, I'm all
along?
in. You bet.
All right, so in this one, I'll be Mr. Johnson and you be
Okay,
Dr. Patel. How about that?
that sounds great.
All right, so I'm Mr. Johnson, and why don't you come in and talk to me
Okay,
first?
you bet. Well, good morning, Mr. Johnson. How can I help you today?
You can't help me. I wanted to see a real doctor, not some foreigner. And a woman? Are you even qualified to treat me?
I can assure you, Mr. Johnson, I am fully qualified to address your concerns. Let's discuss your symptoms.
Well, I just don't trust your kind. I want someone who speaks proper English. So, at this point, poor
I
Dr.
take a deep
Patel,
breath.
yes, yeah, it
Yes.
takes a couple deep breaths. Well, we'll just let our listeners think about how discouraging that might be for poor Dr. Patel. Let's try another one. This one's like on a hospital ward, and this time I'm Mr. Thompson, and you
And
can
I'll be
be
Nurse
friendly.
Emily.
Go
All
for it.
right. Hello, Mr. Thompson. I'm here to check your vitals and make sure you're comfortable. How are you feeling?
How do you think I'm feeling? Just get on with it, you incompetent idiot. This place is a joke.
I'm sorry you're feeling this way. I'll be quick so you can rest.
Just shut up and do your job. I'm tired of dealing with useless staff.
Well, I'm going to
And have a
continue my work, but boy, that one would be a tough one too.
Yeah, yeah. And these are not made up, by the way. These are real. So let me try one other one on here. A lot of healthcare now has moved out of the interpersonal reactions like the ones that we just talked about, and they're now inside of our in baskets, our
Right?
portal messaging. And so this is a new way that we're having to deal with, let's just say, in hospitality.
I'll
So,
be Mrs. Green, and I am going to send a portal message to my doctor, Dr. Lee.
all right.
All right, so my message is I've been waiting for my prescription for days. You're useless.
I'm back in my office banging out. I'm sorry for the delay. I've sent your prescription to the pharmacy, and you should be able to pick it up shortly.
And I'm typing, shortly isn't good enough. If I don't get my meds today, there will be consequences.
Whoa. Okay. Well, I understand your frustration. I type. Please be assured that we're doing everything we can to expedite this.
And I respond, frustration? You have no idea. If I don't get my meds, I swear I'll come down there and make you and your staff regret it. You don't want to mess with me.
Yeah. I'm hoping that these little vignettes are portraying the kind of things that are happening. And these happen
Every
much
day.
more than you would think, much more than you
Hmm.
would think. And they're just a small range of the abusive behaviors that healthcare professionals are encountering. And it ranges from overt racism and sexism to threats of violence, which, on the podcast here may sound a little bit made up. But, imagine if you are on the receiving end of threats like that, and you're kind of starting to wonder, well, I
Be
wonder if I'm going to
horrible.
see this person in the parking lot when I go out to get my
Hmm.
car. It's a problem. So anyway, the impact on staff morale is very significant, and it does make it challenging to deliver high quality care, and it does lead to burnout. And we just simply can't allow this to continue. So I'm really excited today to introduce a colleague who's been gathering together a great team for a long time to try to do something about that. And that's Dr. Elias. So I'm just really excited that today we have Dr. Richard Elias, who's a hospitalist at Mayo Clinic Rochester, who has been working on Mayo Clinic's Complex Behavior Committee. He's the medical director for patient and visitor conduct. And we have an opportunity to engage with him and learn about the work. But before we do that, Dr. Elias, maybe you could just tell us a little bit about yourself and how you got into the work that you're doing around this patient and visitor conduct.
Yeah, thanks very much, Dr. Morgenthaler and Sherry, for having me on the program. It's a real pleasure to be able to talk about this topic with your audience. So, like you mentioned, I am a hospitalist. And so, from the outset, we work in an environment where there's a lot of high emotion and difficult conversations. And so, as a hospitalist, we come into contact with workplace violence and patient visitor misconduct on a unfortunately relatively recent or regular basis. I actually came about being involved with workplace violence and patient visitor conduct via the patient physician communication space. So I was
Really?
working for a couple of years with the Office of Patient Experience, coaching and teaching empathic communication for physicians. And the position came available, and it's interesting. It's actually the patient visitor conduct is conjoined with the medical directorship for experience, training, education, and coaching. And so that was really my principal interest. And it struck me as a little strange initially, actually, that the two were connected. But as I've spent time in the patient visitor conduct arena, I've come to see the wisdom of connecting those two together because so much of patient visitor conduct is about communication, whether it be communicating with the victims of violence, communicating with the perpetrators of violence, but also importantly, communicating with the practice about how to handle workplace violence. So I guess to answer your question, I've come about it from two separate avenues. One of them is just as a hospitalist and someone who's interested in this, and then another as someone whose, I guess, expertise is in patient physician communication.
I actually, before we go on, I want to just stop and back up just a few minutes. I know you from a long time ago, we're early colleagues at Mayo Clinic. And so I know that you've been involved in healthcare work and as a hospitalist for a very long time. In my introduction, I kind of asserted that, gee, there seems to have been a general decline in civility and in conduct. That's what the literature says. But what's your experience been working in the hospital? I mean, why did you get it just strikes me as kind of interesting that, we all go to medical school and nurses go into nursing school. We all go in there. We want to take care of people. There is some screening. And actually, I think most of us are pretty reasonable people when we start this thing. And yet there you are, you're dedicated to teaching me how to communicate more empathically. I mean, there's a story in here. Tell us your thoughts about what's been happening over the past, I don't know, 10, 15 years that you've been working as a hospitalist.
Well, I think you've hit the nail on the head a little bit. There's certainly a perception, and I also share this perception that there's been a general, I don't know if this is a decline in civility or perhaps it's just like a license to say what's on your mind or to have expectations that your expectations will be met and be met quickly. But there's certainly been a trend over I would say, the past 10 years, a harshness or perhaps like an abruptness of interaction with patients in the hospital that I've noticed and visitors. And I think, strangely, it's come at the same time that we've been working really hard to be better communicators to our patients and visitors.
Hmm.
So it's an interesting phenomenon where even when I was a med student, we didn't have a ton of focus on communication as a skill. But over the past 10, 15 years, it's really become front and center. When I work with residents or medical students, we talk so much about communication and empathy and shared decision making. And so it's curious to me to some extent that while we've been working so hard to be better communicators, we've also seen a concurrent rise in this antisocial type behavior.
I guess I'm wondering if the two are related in a way, because I think as the conduct of patients and visitors, and maybe even amongst ourselves, as we're a little less civil, a little less respectful, contributes to burnout. And we know that burnout leads to problems with empathy. And so maybe now you're having to kind of stress the empathic communication and hope that you'll break that cycle. I don't know what you think about that.
I mean, it's an interesting point. So the notion that our jobs have become increasingly stressful, and they have been, and we're busier than we've ever been, and that's causing burnout, which in turn is, I guess, impairing our natural empathy. So we're having to sort of treat the side effects of burnout by teaching empathy. I guess the converse is potentially true as well, that maybe people haven't changed that much, but there used to be like a very rigorous barrier between like the professional, the physician and the patient, and it was like a very understood hierarchical structure. And as those have rightly broken down, maybe people just feel like they've got more license to say things that they were always thinking, but just didn't there wasn't the social avenue to say them.
Gotcha.
Dr. Elias, when we talk about patient and visitor conduct at Mayo Clinic and the programs that have been put together, what does that include? And I know we're touching a little bit on why it's important, but maybe there's a few extra things there you want to speak to.
Yeah, so patient visitor conduct encompasses a wide range of behaviors. And so we tend to rely on the Joint Commission definition of workplace violence. And so workplace violence, as the Joint Commission understands it, is not just physical aggression. It includes things like verbal and written aggression, behaviors like threatening, intimidating, sexual harassment, humiliation, all sorts of behaviors. So physical violence is certainly a big problem and it's on the rise. But there is a lot of what we consider workplace violence, or the Joint Commission considers workplace violence in healthcare, that is beyond the physical aggression piece. And so a lot of what patient visitor conduct does is around verbal and written violence, which is in some ways a thornier problem because physical violence is terrible, obviously, but in some ways there's a clear pathway forward when somebody is the victim of physical violence. There's a channel that I think most of us can understand. Whereas when you're wading into emotionally fraught territory, talking about speech and causing offense or what constitutes bullying, it gets to be very difficult. And so that's where I think those areas are where PVC and groups like what we do can be very helpful to the practice, who sometimes feels adrift as to what really, qualifies as workplace violence.
Yeah, talk a little more about the role that your team, because there's a team for this at Mayo Clinic, that your team plays in supporting the practice when issues like this occur.
Yeah, and there certainly is a team, and I should say that the people who do the work at the coal face of this are, the specialists who work in patient visitor conduct. And I guess what I would say is the process of managing these situations is critical because, healthcare is highly regulated. Speech, like I mentioned, is a very charged and emotional topic. And there's a lot of participants, there's a lot of stakeholders in these episodes. So, like, we think about the patient and we think about the victim of the violence, but there's also other members of the practice that are involved in that patient's care. The institution has an interest, from a legal and compliance point of view. There's a media relations point of view to workplace violence, public opinion. So, like, the public has certain expectations of what people can do and how people access healthcare. And the other point to make is that, like, total exclusion from a hospital is not possible, right? So, like, legislation and the rules and just ethics require us to treat patients in our emergency department and in our hospital. And so the role of, patient visitor conduct is, well, it's a few things. So we're the keepers of our policy because, a transparent and clear policy is really important to be equitable. We're sort of the operations arm of the complex behavior committee. So we help the practice with the practicalities of dealing with workplace violence. So, like, writing behavior letters, doing scripting for difficult conversations, how to handle biased requests that patient might make for a particular type of provider. We provide coaching and resources, like quick reference guides and algorithms. So we're designed to be this one-stop shop, this practical place where people can go for, like, policy, operations, reporting, and resources.
Great, thank you.
Where would you say we've come? You were describing sort of your journey in this. You started out helping others learn about the, disciplines and the techniques for empathic communication. And now, Mayo is, I think, quite far along in our patient visitor conduct policies, procedures. What do you think that journey has looked like, and what are we learning along the way?
Yeah, so I do think that Mayo Clinic is very far along this journey, particularly compared to our peers. And I can tell you where we started is where I think a lot of perhaps the audience members are find themselves even today, which is that, practice groups or units or departments were managing workplace violence in kind of an ad hoc way here at Mayo Clinic historically. So it was just left up to the work unit to kind of decide how to handle it. There was some guidance and there was some stuff, but what ended up happening is you develop these micro cultures where certain areas of the practice were very quick to want to terminate a patient for behavior that might not seem that terribly egregious to the average member of the community. And then there were other areas of the workplace or of the workforce where egregious workplace violence was happening and nothing was really being done. And so the big move I think that we've made is to centralize and standardize the process of managing workplace violence, because you want to be supportive of the staff. So you want to make sure that all your staff are getting the same protection, but equally you want to make sure that you're being fair, equitable, and transparent with the patients, because we get these applications now for, like, the overturning of an old termination, for example, like where they were just, like, banned from the whole practice 10 years ago, and we look through it and it wouldn't pass muster from, like, a systems point of view today in terms of going through the due diligence and making sure this patient's treated fairly. So it's like, on the one hand, you want to make sure you're supporting all the staff equally,
Mm.
and on the other hand, you want to make sure that you're being fair with the patients. And so I think the journey has been consistency and transparency across the enterprise.
Mm.
Yeah, and I remember the days where, like you said, there was a process, a policy in one of our sites or locations, and 20 miles down the road where another site was, it was totally different. And so patients would unfortunately take behavior that was unacceptable from one location to another. And then it just caused problems for those staff to be able to manage. So having this standardized opportunity where everyone's on the same page about how do we respond and address those issues is just a huge win.
Yeah, it's getting into the little weeds of our definitions, but so when we terminate a patient, we're terminating that patient across all of Mayo Clinic. There's also an avenue whereby patients can be dismissed from a practice but those are meant to be for non-workplace violence related reasons, for like things to do with non-adherence to treatment regimens or things to do with the therapeutic alliance. But what was happening in the previous era was that, like you say, practice areas were just dismissing difficult patients from their practice group for violence, essentially, or for verbal abuse. But and that was where it would just end, and so the patient would just go along and continue that behavior in other parts of the practice. So one of the big, I guess, revolutions has been to say, if you're terminated for workplace violence, you're terminated across the whole enterprise.
And I suppose having a uniform electronic health record so that that's communicated to everybody is an essential part of that, really, because otherwise, how do you know?
Absolutely. Yeah, yeah. And in going back, sometimes it's very helpful to be able to look at the electronic health record and see what was documented at the time that these episodes occurred. Because it's a pattern of behavior. So like we talk about this escalation curve in patient visitor conduct. Like a terminated patient, it's rarely their first episode of difficult behaviors the day they get terminated across the institution. It's usually a pattern of escalating behaviors. And so being able to go back through the record and see that pattern is super helpful.
Just to help those who are listening with us today, when you talk about termination, you're talking about a formal arrangement where Mayo is informing them that they can no longer receive routine or outpatient care at Mayo Clinic, right?
That's exactly right.
I mean,
Yep.
if they had an emergency, they were hit by a truck or something, it's not like we're going to refuse them care or something like that, right?
Absolutely no. So like the legislation requires us to look after patients who come to our emergency department for acute care, and we've many terminated patients that still access our emergency department for emergency care. It refers to outpatient elective care essentially. But it goes well beyond just sending them a letter. And this is another part that I think is underappreciated by the practice sometimes, is there's a lot of logistics that goes into actually instituting a termination. It's not you send them the letter for sure. You got to send them a couple of letters, but there's a whole process of like making sure all the other members of their care team have a chance to give input. Like you'll have a situation where there's an episode that happens in one subspecialty, but then you have to ask their primary care doctor about their psychiatrist about the risks of abandonment or whether there's other care they can't reasonably get outside of Mayo Clinic. And then there's all sorts of technical things that go along with terminating a patient, like you have to block their access to the EHR and to the portal messaging system, but legislation requires them to have portability of their electronic health record. And so there's a bunch of technical stuff that happens in the background to bar them from electronically harassing staff while still giving them access to their medical record. And it includes like the retail store, the pharmacy, places that you wouldn't think. The termination is truly like across the board. So it's a bit of one of my colleagues in patient visitor conduct, he describes it as being like unscrewing all the light bulbs. Like people think that terminating a patient is like flipping a light switch, but it's actually more like going around the whole institution, unscrewing all the light bulbs, because it's pretty complicated.
Yeah. I have to imagine this is complicated. What does a healthcare organization who's starting to address this concern do? I mean, where are their resources and tools? What do they do?
Yeah, that's a great question. I think it's tough to get off the ground with something like this. It is resource intensive. I guess what I would say is at a minimum, and this is not just me saying this, but OSHA and the Joint Commission, they have guidelines. At a minimum, there needs to be a mechanism that every hospital has for reporting workplace violence. And there should be a mechanism for tracking and monitoring workplace violence episodes. And there should be somebody, and ideally a group of people, who are responsible for handling these workplace violence episodes. And so when it comes to practical tools, I say the Joint Commission has a workplace violence prevention sort of compendium of resources on their website that I think is helpful. And OSHA's got a nice document. I believe it's called Guidelines for Preventing Workplace Violence for Healthcare and Social Services Workers. And it's about 50 pages, very highly readable. It's basically like the minimum product that you need to have a workplace violence mitigation program in healthcare. I empathize with the listener who is trying to build this from the ground up. It's tough and there's a lot of moving parts.
Yeah, just a quick thought too, as we talk with other healthcare organizations and many, of course, that aren't the size and scope of Mayo Clinic, there even seems to be still this acceptance that it's just part of the work, it's part of the job, that I'm treated poorly or yelled at or whatever. So, what are your thoughts about how you can even just start to change the mindset of staff in an organization around it's okay to have patient and visitor conduct rules and policies, et cetera?
Yeah, that notion of it's part of the job is so ingrained in the culture, particularly in some places more than others for whatever reason. I remember at one point we were going to do a public education campaign here at Mayo Clinic, and we were going to call it "It's Not Part of the Job" because that phrase is just so pervasive in healthcare. So that is a difficult problem because there is this pervasive notion that workplace violence is just part of working in healthcare and it's part of the trial by fire of being a healthcare worker. I guess what I would say to that though is that workplace violence is extremely pernicious to the workforce. Like there's pretty good studies, and Dr. Morgenthaler alluded to them, that I guarantee if there's an institution that's not addressing it, it's costing the institution a lot in terms of days off from work due to injuries, attrition of the workforce, low morale, burnout. It's a very expensive problem, very difficult problem to ignore. I don't have an easy answer for how to change a culture of an institution, but I would say that like educating staff and supporting staff in reporting is a big problem too. One of the things that really helps with reporting is I think there's two big things that help with reporting. One of them is staff have to honestly believe that management cares about workplace violence, that if they report it, they'll be supported and they won't get in trouble and nobody's going to roll their eyes. That's a super important piece. And then the other part is that there needs to be like an easy place to do it. Reporting workplace violence is actually kind of like confusing because you're like, who do I report this to? Do I report it to security? Do I report it to, occupational health if there was an injury related to it? Do I report it to a patient visitor conduct type group, patient experience? One of the big steps that we made was just having a single place, like a wizard on our website where people could report their workplace violence, and then it would send the reports to the relevant party. So patients could or staff could go to one place and report. So I think those two things are really important is buy-in from management, like vocal buy-in from management, and an easy place to report is kind of the minimum.
I mean, whenever you start talking about changing culture, you have to start talking about leadership.
Uh-huh.
As you just
Absolutely.
did. If the leadership doesn't make it a priority and back that with their words and actions, then you've got a problem in terms of changing the culture. So thanks for that.
So, any other just first steps? So, maybe we've gotten past this, it's not okay. How do we start bringing it together, maybe that one place, or any recommendations from your experience on how we started here at Mayo?
The way we started at Mayo was with the philosophical realization that we've already spoken about, which is that it makes good sense from both a fairness point of view and from an efficiency point of view to centralize these processes. So I think like if I was a leader at a healthcare institution, I would say an investment in a centralized office or a centralized place where workplace violence can be addressed is a huge win, not just because it gives a better service to the victims, but it also is I think a cost savings because it allows the frontline healthcare staff, it offloads this very arduous and time consuming task away from the practice. And so like it's a huge time savings as well. So I would say invest in a centralized office. The other thing I would say is come see what we're doing. I'm biased, but I think that Mayo Clinic has the most advanced patient visitor conduct program in the country, maybe in the world, when it comes to a well-oiled machine. We're not perfect, but like a well-oiled machine that manages these cases efficiently. And I'd be happy to hear from people from, other hospitals or come for a visit. Or I know like our care network hospitals, I think have access to our expertise through consulting and all that. I would strongly recommend using those resources if you're building a program from the ground up.
Wow. Dr. Elias, I just want to thank you again for devoting your time and your expertise to our podcast and for our listeners. There's a lot of information here, and this is such important work. So I just want to express my gratitude to you, first of all, for the work that you do on my behalf, on the behalf of all my colleagues here at Mayo Clinic. And I also want to express gratitude for sharing your wisdom and your experience with our listeners. Anything
Thank you.
else that you want to add?
No, I'm very appreciative for the opportunity to come onto this platform and talk about this important topic. I think there's a tendency in some institutions, and to Mayo's credit, we're not one of them, to really kind of sweep this issue under the rug, and not really want to talk about it. But even being invited to come on and speak about this difficult topic that doesn't always cast your institution in a glowing light, I think is really super important. And so it's a credit to yourself and Sherry that to have me on and talk about this. And it's something that is definitely on the minds of the people who are looking after the patients.
Thanks again. So we have come to the end of our podcast. We're really glad you could join us, and we hope that the information that's been provided here in this discussion has been insightful and valuable. Again, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we would be grateful if you'd leave us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listen to us. You can also follow us on your favorite podcast platform. Please let others in your organization know about the podcast so the information can be spread. Until next time, goodbye.